Welcome to the Senior Rehab Podcast.
The podcast for rehab clinicians that want to better serve older adults.
And now, your host, Dustin Jones.
Hello, friends, and welcome to the Senior Rehab Podcast. Thank you for tuning in to this episode. I'm very excited to introduce you to Dr. Kathy Shirley. She is a physical therapist. She has her OCS, she has her GCS, and she has a 35-year career working with patients. And now she's transitioned into the academic setting, departing her wisdom on the students at Texas Women's University PT school. I'm very glad I got to meet her because her focus in academia is how to change perceptions of geriatrics in students. And if you've been listening to this podcast for any amount of time, you know this is a recurring theme. How do we change the perceptions of other rehab clinicians and how they view older adults and how they work with them? So you'll love this interview. This is one of those interviews where it's just gold for us young therapists that don't know a lot. We don't know what we don't know, and we have a lot of hard lessons ahead of us. But Dr. Kathy Shirley is gracious enough to share them with us on this podcast. So enjoy this. I know you will. There's a lot of value in it. And without further ado, Dr. Kathy Shirley. Welcome to the Senior Rehab Podcast. Thanks for your time this morning.
Oh, thanks, Dustin, and I'm really happy to be here.
Yeah, I'm excited to connect with you because ironically enough, we met at CSM after the Changing Perceptions in Geriatrics talk by the Fox Rehab crew. And you told me just kind of what you're doing now in academia. And so I'm really excited to get in to this topic. But before we kind of jump into that, I would love to hear about your career. I know you've got a pretty amazing and diverse career, but let me in on just kind of your path up to where you are now.
Well, it's been sort of a long and winding path. And, you know, I encourage young physical therapists or new physical therapists to the career to be open to long and winding paths. So what I thought I was going to be doing in the beginning is really not what I'm doing now.
Yeah.
And what I thought I was going to do 10 years ago is not what I'm doing now. So try to be open to that. But I started out typically in physical therapy with an interest in orthopedics. And in the beginning, my university was one of the first to actually have a manual therapy curriculum. And I went and did a manual therapy, we called it more manual therapy back then, internship at Fort Bragg, where 36 years ago, you know, we already had entry. They were doing first line treatment. There was not physician referral. So, I mean, that was going on for a long time. And I saw that and I thought, oh, I would love this. So orthopedics became my passion. However, my first job was acute care physical therapy, which I really enjoyed and gave me an idea of medicine and overall view of physical therapy and what I could do. And then I moved into neuro because of that job. I was in North Carolina, in the belt, the stroke belt. And then I moved to Illinois. And I was working with a really passionate orthopedic physical therapist who encouraged me to really improve my orthopedic knowledge. Yeah. So that started me down the road of the OCS. Then I moved to Florida and was really exposed to the geriatric population. And I knew I needed to understand that population better. So that moved me down the road of geriatric physical therapy. And then I started to realize that, well, if I'm in geriatrics, I really have to understand the vestibular system. So I did the vestibular competency. And in between all of that, I became very interested in yoga and different alternative movement programs and incorporated that within my therapeutic exercise concepts. So, you know, I just sort of went where the path led me and where the questions were leading me and my curiosity. And I tried not to stay in little boxes.
Yeah.
So what brought me to then academia. I just had an opportunity to move into academia and I really wanted to do that in order to change what is going on in geriatric physical therapy as far as the perception of our students, and to, have somebody that they can see. I love what I'm doing, and I am very proud of what I'm doing, and it takes extreme skill to do this well. So that's something that I don't think we talk enough about.
Yeah. My gosh. So you've been all over and have quite the experience. That's impressive. So tell me, when you were, moving around, had all these job changes, tell me about that period of time where you began to become interested in geriatrics, just kind of that process. Was that a pretty quick shift once you were in Florida, or did it just take time for you to see like, oh, I really like this population?
Well, I always liked the population. It was just that I had such a major exposure to it in Florida.
What setting were you in Florida?
So in Florida, actually, I started in a work hardening program. So it was the beginning of work hardening.
Okay.
It was then mostly orthopedic based. So that was certainly not a geriatric program, but I had the opportunity to move into a private practice with an occupational therapist, and we were going to do a rheumatology based practice, which is what we did for 12 years. So that, of course, I am seeing an older population in rheumatology, but also a younger population. But that was really the kickstart to geriatrics. That was what forced me to know that I do not know enough about this population, and I need to get better at it.
What skills that you had previously do you feel like really benefited those patients?
My orthopedic background, my manual therapy skills.
Yeah,
that was a definite benefit. My look at the whole system, because I am also adult NDT certified. So I looked at the whole body when I watched people move. I looked at how to facilitate movement. So what was helpful was that I had this maybe diverse background that I could bring into a population that requires a diverse background, because every single system typically has to be tweaked.
Yeah.
And we have to be aware of that.
Yeah. So if I heard you correctly, you said you can use manual therapy on geriatric patients?
All the time. And I think you had a speaker earlier, that was talking about that. So yes, I think many times, we're afraid of that. We're afraid to touch or move, and they benefit greatly. That population benefits greatly from orthopedic manual therapy. And I think our profession has a problem with sort of compartmentalizing everything, and you only do this for this, and you only do this for that, and in geriatrics, if you think that way, you're really not benefiting your patient. I personally think in all patients, if you think that way, you're not benefiting them, but you definitely are causing problems in geriatrics.
Yeah, there's many more factors involved in those cases for sure that we have to consider. How were those hard lessons that you learned, that in that 12-year period, you started to work with geriatrics, and you said you went and pursued more knowledge and continuing education about that field. But what were some of the hard lessons that you learned just from the day-to-day practice in your clinic?
Well, probably the hardest lesson that I learned was I had to be gentler for some patients, especially in rheumatology. And I didn't understand the dosing of therapeutic exercise or the dosing of manual therapy. It's different. And again, I was also working with some of the inflammatory rheumatology type problems, which is a whole nother aspect of care on top of geriatrics, So, but I had a physician once say to me, as I was first working in the population, said, you're really, really good with my patients, and I really see great outcomes. But they tend to generally do better if I have them on prednisone. And so that made me realize I was being too aggressive. And I was like, okay, I got to remember.
Yeah.
So you learn by making mistakes. And I think sometimes we have to help everybody understand that, no, we don't want to do harm, of course, but sometimes we're going to make a mistake. And if we overtreat or if we undertreat, we have to recognize we were overtreating or undertreating, and we need to make a change.
Yeah. And that lesson learned, that was a tough lesson for me as well. But I think it's also can be a strength. Just especially coming from that orthopedic background, working, with, more active individuals or maybe even athletes, you have this mindset that you're going to push people.
Mm-hmm.
And that isn't necessarily all too common in geriatrics, as you're aware of for sure.
Right. Right.
But yeah,
We tend to undertreat.
Yes,
Yeah,
yes, definitely.
Yeah.
So yeah, I've definitely learned some of those lessons as well from the physician, from the patient, from the caregiver, saying, "Hey, you need to tone it down a little bit."
Right.
That's always great. So those were the tough lessons learned. What are some kind of pearls of wisdom that you've gained, just over the years that have just really benefited you in working with geriatrics?
Well, just in the general mindset is the appreciation of the geriatric population, especially when they see somebody who truly believes they can get better.
Wow.
So that I've had many patients say to me, "You're the first person who gave me any hope." And that should not be, we just should not have people saying that to us. We should not be the first person. And they're saying that to me after they've seen multiple physical therapists.
Wow.
So it's not that they've just been hearing this from the physician. They've been hearing this from our profession.
Yeah.
So that is, we give people hope. We have to remember the potential. And that's the difficulty, I think, is that because of ageism, because of just we generally see sicker individuals in physical therapy. And so we start to think that that's the norm.
Yeah.
And that is not the norm. And then we do not realize what the potential is. And if we don't realize there's potential, then we tend not to try to improve anybody because we're like, oh, we've written them off already. Well, they're just old.
Yeah.
There's nothing we can do. And that's not the case. I think it's much better. When I was first practicing, I know it's sort of hard to think, oh, it was worse, but it was worse. So I definitely see the glimmer of hope and the light in the tunnel. But I think now is we really have an opportunity in geriatrics to make big strides, big gains, and they're needed because we have the aging population. The tsunami is upon us, and we have to be able to take care of this population that will be in front of us, and that is in front of us now, but will only be gathering more momentum.
Yeah. That's interesting because I haven't been practicing too long, but I just think in my, I guess, perception of disease and health of how, when I was younger, I definitely perceived some of these diagnoses as kind of death sentences. As, say, I grew up in West Virginia, so, diabetes, strokes, all these different kind of chronic metabolic conditions they were so normal. And I just thought, that's just what happens in life and there's nothing you can do about it. And then, the more you learn and the more people talk about, whether it's physical activity or nutrition or whatnot, you see a lot of these things, can be dramatically impacted for sure. And I know that's really empowered me to be hopeful with these patients. Have you seen, a shift in terms of how people perceive some of these diagnoses that they get, whether it's, osteoporosis or sarcopenia or degenerative disc disease or any of these things that they get tagged with? Do you see a mind shift over the years?
For our patients?
Patient or provider provider.
I think there is a beginning shift, but in general, no. I do not see patients being given optimism to any of these diagnoses or really how to manage them. I think that's more rare than common.
Okay.
But maybe before it just was never happening.
Yeah.
But I do believe we're getting there. We're getting there, but it's not good enough.
Yeah. In your career, have you seen a big shift in kind of the characteristic of the geriatric population in terms of their activity levels, their interests, what they want to be able to do?
It's starting to change because we have the baby boomers.
Yeah.
So, if I have somebody who's maybe mid-80s from that time frame, growing up more in the 1930s or was born in the 1920s, that was a different generation. They were They work differently. They did not exercise, understanding the culture of how that person was raised.
Mm-hmm.
But if I have somebody who's in their 60s, the beginning of the baby boomers, that person is definitely talking to me differently about activity.
Yeah.
And I think that's also something that as a practitioner, you have to be aware of. You have to know, how was that person raised? What is their personal perception?
Mm.
And then how can you work with that to get what you want, or, to help them meet their goals? Because everything is about what is that person's individual goal. It is not about what's our goal.
Yeah.
It's about what is their goal and how can we make our goal meet their goal, and everybody's happy. It's win-win.
Mm.
Well, so there's a little bit of negotiation that has to go on. There's always more than one way to get it done.
More than one way to skin a cat, right?
Yep. Mm-hmm.
So in Florida, I've never been, down to Florida in terms of a therapy capacity, but that would be an interesting place. But I'm wondering, do you have any good stories or any memories of certain patients that just had these crazy goals in terms of, very athletic individuals or people that wanted to do some pretty amazing things?
Yeah, well, that's the one nice thing about Florida. It really changed my perception. So you'll see both extremes there, the very ill, the very frail, but also then the very capable. And when I moved to Florida, I was really having fun with the triathlon community. And being in that community, I met many older triathletes. And they were better than me. And so then it, really gave me a different perception of, potential.
Yeah.
I was like, oh, this is great. I can be like them. I can try to be as good as them now. And they're 30 years older than me, 40 years older than me.
That's incredible.
But I had a great patient who played softball with a group that was called the Kids and Cubs. I think that's right. And it's in St. Pete. And they all have to be older than 70. And they wear these little white uniforms with a black bow tie. I mean, it's just, and they play on the field. And he was having some balance difficulties, and he was an outfielder, and, he had to be able to reach over his back to catch the ball. And,
Wow.
And we had to work through all the different orthopedic problems that he was having, the different balance problems. And his goal was to return to play, and he was 75 years old.
Yeah.
So, and he was just such a fun person, and I was like, oh yeah, we can do this. There's a way to get there. So, that kind of, and I think sometimes, both the students and our other colleagues, they don't realize that there are a lot of older adults out there with those goals. And we could help them maintain higher physical activity, higher fun, functional activity, if they knew that this was possible.
Man. So this will be different for each patient, but I'm wondering, with some of those individuals that have these higher functional goals, whether it's to, be able to play baseball or, ride a road bike or whatnot. In general, what are some of the big differences in working with them to reach those goals as compared to a younger individual that wants to be able to play baseball or, ride a bike?
Well, I think in many ways it's the same. Like, you have to break down the movement patterns. You have to know what the functional abilities are, what the strength is for that individual, and then build upon it. So I think that's the same. I think what we might make a mistake in is helping people understand that rest is really, really important. And what do we mean by rest? So going back again to the dosing of their activity, and then the diversity of their activity. So sometimes, and younger and older individuals do this, we like to repeat what we're good at.
Yeah.
So we don't always like to work on maybe flexibility or maybe some really small stabilization type exercise. So I think with the older adults, but again, many times it's for everyone, we have to make sure they understand the why. Why are we asking for them to do this particular movement, this kind of dosage of it? Make sure it's your flexibility is a focus. Stop a particular exercise for a few weeks. If they really understand the why and how that is related to their ultimate goal, you will have buy-in. So, it's that idea of compliance.
Yeah.
And it comes with communication. So I think that maybe the difference is the idea of how you have to communicate what you need done.
Yeah. That's been a theme on this podcast that I'm quickly learning. Definitely just several interviews that I've done, just that the communication piece of really understanding the patient and their desires and motivations, for sure. So the experience you have is amazing. From your perspective, just in general, geriatric physical therapy, what could we be doing better as therapists? And you probably touched on this before, but if you were to answer that question, what would you say?
Well, I think, and this isn't even technique wise, okay? I think as therapists, we need to be better about promoting how important our involvement as physical therapists in this population is. And to others, like I think the orthopedic physical therapists are very good at talking about what they do and what the benefit is and the pride in their work.
Yeah.
And the geriatric physical therapists we just don't hear them that much. Maybe it's that we don't have the platform. I'm not sure what the difference is, but we need to sort of stand up a little taller. And when people start asking us, why do you do geriatrics?
Why not?
We really need to be prepared to answer with the positives of what we are doing for that population, for society in general. Because not only when we are really doing a good job in geriatrics and explaining to a person how they have control over their aging, some things we don't have control over, but many things we do, that helps the younger person age better. Because the younger person now understands that, oh, you know what? When I get older, it isn't just about doom and gloom and decline and decay. I have some control over staying well. So this really moves into the wellness focus that physical therapy has been trying to access, that we are part of that. How can we keep people well throughout the age spectrum? Not just, we only deal with somebody who's in their 20s or we're only doing athletes.
Right.
I tell my students all the time, you have the greatest opportunity in outpatient orthopedics to change the geriatric patient that might walk in your door 30 years later.
Oh, that's a good one. And I wonder if they actually grasp that.
I don't know.
They will about 3 or 4 years when they're out of school.
Sure. So I'm hoping.
So what avenues do you feel like are effective for us to kind of talk about what we do and to be proud of our work and help change perceptions of how we can benefit the geriatric population?
Well, I think these podcasts are wonderful.
I paid you to say that just to let the listeners know. I'm just kidding.
No, and that was really my enjoyment for starting to listen. And actually, I had a student tell me about your podcast. So, I think my students realize that I'm looking for these different things, and they'll send me like a link to some really great video about an awesome older athlete. And it's great. And so somebody sent me a link to your podcast, and I was like, oh, this is the kind of platform to do things at CSM that we were seeing. I was really pleased with the geriatric content this year. The networking opportunities. I think we need to encourage everyone to become involved in some way, even in academics. Team up with a researcher. The clinicians are the ones who have the questions. And the researchers are the ones who want those questions so they can go ahead and design something to give us answers. So try to be a guest lecturer, go into the student classrooms. We need people who want to be champions for geriatrics to be speaking. So instead of just sort of sitting back and saying, well, this is the population I treat. That's it.
It is amazing to, I'm just from my experience so far, just with doing this podcast, it's been really cool just to see people just come out of the woodwork that share that passion, that share that excitement. And especially there's nothing better than getting, just the random, video of the 75 or 80-year-old that's deadlifting a barbell or pushing a sled or something like that. And that is very, very encouraging. And I struggle though, because I feel like we've got something going here on the internet and with podcasts and whatnot. I mean, if you're, I don't know if you're on Twitter or not, but there's lots of people talking about this stuff on Twitter and Facebook as well. But I just am racking my brain of how to reach the common, therapist that's not necessarily on these things in terms of podcasting or social media and whatnot. And I don't know how to go about that. But I don't know. What are your ideas?
I think that, whatever work setting you might be in, to be doing an in-service, to be having a journal club, to be discussing patients, just being there in the community. So like I still only work 1 day a week in a clinic because I'm full-time faculty now. And so I'm just they all know to ask me any kind of question, and that I will, if I don't have a patient at a time, I might just walk in to observe them with a patient. So that you're just accessible, Oh, what do you think about this? How would you look at that? Just on Monday, I did a co-treatment with one of the other physical therapists who is not a geriatric physical therapist, but had a complex geriatric patient. And that's the other thing that I don't think the general physical therapists, or especially our students, understand that, the demographics for the aging population is over 47% of the outpatient population is geriatrics. So like everybody thinks, I'm going in to do outpatient orthopedics. I'm not going to see an older adult. I'm like, yes, you are. So we have to help, and they need to know how to take care of that older adult, because it can't just be the geriatric specialists. There's not enough of us.
Yeah. That reminds me of this past Monday. I was going to email you and pick your brain on this, but I gave an hour lecture to athletic training students at a small university. And it was very interesting because, all these are freshmen, sophomore, athletic training students. They're all about, high level performance, elite athletes. And I basically gave them the stats on our aging population and told all of them that, most of you are probably going to be working with older adults in your career. And I said that just knowing, where a lot of athletic trainers end up down the road. And I just saw their faces kind of deflate. Just kind of, but then, we talked about, what's going on in fitness and, just athletic training and then how that can be bridged with geriatrics, and like, oh, okay, it's not, dirty diapers and TheraBand exercises. And so that was really cool to see.
And I think that's a big thing, is that it's the perception. The perception of what geriatrics is.
Yeah.
And normally when you talk about geriatrics, like the first thing somebody will say is, oh, okay, we're talking about somebody in a skilled nursing facility. And I was like, that's less than 5% of the population is in a skilled nursing facility. I've rarely worked in a skilled nursing facility. The majority of my work has been in outpatient orthopedics. And so I always thought everybody understood that. That was, but I really got the idea that no, people do not understand that. So it is what the perception is. And then we have to help change that perception. So it's making sure they understand what we think geriatrics means. It's not what they think it means.
Yeah. So I think that's a good opportunity to kind of dive into what you're doing in academia. So kind of tell us the transition into your current role and what you're doing.
Well, so I had another move. I keep following my husband.
What does he do? Why is he moving all over the place?
So we moved to the Dallas, Texas area 4 years ago, almost exactly 4 years ago. And so I was in a total uproar about what was I going to do professionally, because I had been in Florida for 25 years, super established. So I had an opportunity as I was trying to network and find other vestibular physical therapists. I met faculty from Texas Women's University, and they had an opportunity for what was called the supplemental learning coordinator. And it's somebody who is a lab assistant and also a special tutor for certain, if anybody maybe is struggling. And then they have defined time where students come in to practice their skills under the supervision of that supplemental learning coordinator. So I had the opportunity to enter into a DPT curriculum and see the entire curriculum.
Wow.
And then I decided, well, this was a great opportunity for me to go ahead and do my transitional doctorate. So I worked on that for 2 years. And my capstone project was specifically related to this idea of perception. So I wanted to look at, do the Doctor of Physical Therapy students, does their knowledge and their attitude about geriatric clients change when they're exposed to geriatric curriculum? And I also tried to infuse a optimal. So I had the opportunity to teach their first introduction to geriatrics.
Wow.
And so these are the first semester students. They've never had any kind of introduction to, they don't know anything the first semester, right?
Right.
So,
they know everything at that point, right?
So I had a lecture and lab series that was just their introduction. And I tried to really infuse optimal aging, the idea that the potential that aging is not a disease, what is truly disease versus what is simply some minor age decline. What is the ability of somebody to stay well? And then, what are the things that we might tend to see? What are the demographics, et cetera? And I did like a pre and a post test of that. And I tried to do a lab that was really more an empathy lab of understanding the different challenges. If somebody might have visual challenges, if they might have vestibular challenges, if they might have some orthopedic limitations, and then how could they function? And then I just did that pre and post test and I asked them for their reflections on it. And it was so interesting to see the outcome of their perceptions. So their perceptions did change with exposure to this, and their knowledge did change. And now that was just like a pilot. And so now I'm working with one of the PhD OTs at Texas Women's University on a combined OT-PT research program to look at this same concept. Because it's not just PT that's in trouble. I mean, medicine, physicians, physical therapy, occupational therapy, speech pathologists, the least area that anyone wants to work in is geriatrics. Now, and this is going to be the biggest need in the future. So we have to do something different. And people have been talking about this since the 1960s, but very little has been done to change the education and the focus and the understanding. So, now we're sort of at do or die because we have a big population that's going to be out there, and we need to be able to take care of them.
That kind of reminds me of the primary care physician epidemic. We just need so many primary care providers, but no one's going into that.
Right. It's the
specialty.
Same thing.
Yeah.
Right. This struggle is everywhere.
Yeah.
So, and there's multiple things behind the struggle, but one of the big things is the perception and the idea of ageism in this country and ageism within our own profession. So, we have to be aware of that.
Yeah. So tell me just your thoughts on ageism within, the therapy profession and just kind of your observations.
Well, it comes with the idea that as you get old, there's nothing we can do about you. You are no fun. You are grumpy. There's, it just the litany just keeps on going. And that's not it at all. It's very interesting to me. I don't understand where it came from. Who did you see and why do you go ahead and just give that behavior to ageism? I've seen that behavior in somebody who's 20.
Yeah.
But you don't say that's a problem for them. You don't relate it to their age. But as soon as that behavior is occurring in somebody over 65, it's because they're old.
Yeah.
So, and maybe, my sort of view on this is because of the exposure I had as a younger therapist and what I've been able to observe. And also, I'm sure part of it was my exposure to my grandparents who aged very well. And I thought that was normal until I went to PT school.
Yeah. Yeah.
So, and then in PT school, the only thing I'm taught is how everything goes south. So once you get to a certain age, then nothing's good, and if you look at the stats, if you just look at the stats, but then you got to look at, that's why I love getting these videos. Then you look at the person doing CrossFit who's 75 and the person who's, running a marathon, or the 100-year-old in Britain who just broke the record for the 400. It's like they're all over there.
Yeah.
So we need to look at that more because that helps us counteract, what we have in the back of our head that is saying, well, when you get old, you just get old and you die.
Yeah.
And yes, we do get older and we do die. That is part of it, but we can maintain high function for as long as possible.
Yeah. Where'd you grow up?
Oh, well, so here comes part of the diversity again.
Or where was your grandmother? We'll say that.
Oh, Youngstown, Ohio. Can you recognize a little bit of the accent?
Okay. I'm hearing it now. Say water for me.
Water.
Okay, yeah.
But I say orange, and so everybody always jokes about that. But I'm a military child, so I traveled a lot too. But I spent about 7 years in Youngstown, Ohio.
Okay.
Yeah.
Sorry, I just asked that because I just want to get a glimpse of the region that you grew up in or that your grandmother was in.
Mm-hmm.
Just me being from what many would say the unhealthiest part of the country. But I mean, what you said about, just aging is this terrible process that, it's just going to go downhill from here. And, it does to some extent for everyone. But for me, my perception was definitely, that everyone's going to get diabetes. They're going to have a heart attack. They'll have a stroke at some point. They may get a foot or 2 feet cut off from their lower extremities. And that's just how things happen. So it's interesting just to see how my view was back then and how it's changed now, but even how my views growing up, how that really impacted how I worked with older adults in therapy. Because it definitely, led me to be a little more conservative and not challenge them in the clinic for sure.
Right. And that goes back to what is our perception,
Mm-hmm.
And I went to a geriatric course recently, and one of the speakers put up a slide showing a cross section of the thigh, and what happens with aging and the fat
Mm-hmm.
infiltrates and all this. And I had seen that slide before,
Yeah.
but with a slide of a 70-year-old triathlete beside it to show the difference.
Yeah.
And so I put my hand up to say, well, that we could have more potential than that. And he goes, well, but that's not who we see. I was like, but if we don't tell people what the potential is, they're not going to go for it.
Yeah.
Oh, and that was, so ageism is ripe in our profession.
Mm. What would you say to the listeners, people like me that are just kind of, out and about, just doing our work in the clinic, whether it's outpatient or home health or skilled nursing facilities, acute care, whatever setting we're in. I mean, we're all working with these people. What could we do to kind of help in your efforts to change perception? Just some of the practical tips that we could do on a day-to-day basis.
Well, I think is to remember to always keep in your mind a picture of a healthy or a optimally aging older adult. And remember that possibility is there. So every time you're seeing somebody who maybe is frail, because the people that we help the most are the most frail.
Preach it.
We make the biggest difference in the most frail individuals. So if we can always have that picture in our mind of the potential, I think that we're sort of speaking to the choir. It's like, So the other thing is to make sure that you talk about the potential, that you always bring that up to people, that we show the joy that we have in doing our work. We surround ourselves with people who are open to this kind of progress, to asking the questions of how far can we push? What can we do? What can we change? Because, the changes aren't made by following rules. The changes are made by breaking rules, by trying things that are different. And, we have evidence-based practice that is telling us that resistance work is important.
Yeah.
Okay. But when I first got out of school, nobody was talking about that. So the people who came up with that evidence, who started studying that, were breaking a few rules.
Yeah. That's so true. We had a good discussion in the Senior Rehab Project Facebook group about deadlifting and just how many rules that are broken when we're talking about deadlifting with older adults or even people that have diagnoses of osteoporosis. And I mean, there were some therapists in this group. I won't mention any names, but they actually train, or they'll load, lumbar flexion, that they'll intentionally have people not necessarily do a hip hinge with a neutral spine, but they'll have someone actually flex their spine. But just this very, very gradual progression, very slow progression of just kind of putting more stress on the vertebra to allow them to promote and get stronger, but not necessarily to the point where they're going to fracture. And I know that's a fine line, but this therapist was having amazing results with this person. And it was going against everything, that we learned. It's like, don't flex the spine. But he was saying, well, some people may benefit from it, and if you go about in a very meticulous way, you can get good results. And I love to be challenged in those areas to think differently and just to really break down those rules. So that's very, very good advice for sure.
Yeah, and things like that, or being observant, like taking a calculated risk, but also understanding that our first job is to do no harm.
Yes.
So and looking at it, well, I'm going to try this, and those are the kinds of questions we want to bring to the researchers. And help them design a study that can then really give us some valid outcome and guidance to other clinicians who would like to do this.
Yeah.
Because yes, it is a fine line, especially in osteoporosis. Now we definitely have, like Sanaki has been doing research since the early 90s that definitely tell us loading extensors is going to decrease fracture risk. We know that. That's been really replicated. There's no problem. But nobody has looked at what happens if we start. Well, he's looked at flexion. He said it increased risk of fracture.
Right.
But, how do we have to look at that in maybe greater detail? And what type of person? Are we talking about osteopenia, osteoporosis at, with a DEXA scan of a -3? Where are we in this?
Yeah.
So, but those are the kinds of questions. And that's why I really would like to tell the clinicians to try to have some sort of networking and interaction in academics so that we can keep academics as current as possible for what is really happening in the real world clinic. And then how can we try to infuse that within the curriculum? Everything changes slowly. Clinical practice changes slowly. Academic curriculum changes slowly. But if we have more communication between clinic and academics, I think that we would all be happier.
Yeah, I agree. All right, let's shift gears a little bit. Let's do some quick questions. Your responses do not have to be quick. Okay? All right, let's go way back to the beginning of your career. What would you tell your 25-year-old self?
Oh, you did a good job going with the flow.
That's the truth.
Keep an open mind. I was glad I kept an open mind, and sometimes I was really rigid. So maybe maybe I would have moved faster if I'd been a little bit less rigid. I had the opportunity because I worked in different places to be forced to see things that were different.
Yeah.
And maybe if I'd stayed in one place, I would not have become as diverse or had as much met as many people that helped to make me diverse. So to my younger self, I would say, keep that open mind. Never just say, this is what I'm going to be doing. And it's good to have goals. Okay. I'm not saying that you want to have goals, think about what you want in 5 years, but be open that it could be totally different and that's okay.
Yeah. I really hope that your students value that advice and are really, really getting it in their head. There's one professor that comes to mind that said that same thing, and I was very stubborn and told it's kind of ironic. She's actually she specializes in geriatrics, and I did my capstone project with her for the sole fact that I thought it was easy and I wouldn't have to put a lot of effort in. I'm lazy, if you haven't noticed yet, but it's funny because my capstone was on fall prevention in older adults, and I made a website, and I mean I was dead set on athletics, working, in sports. And I just wanted to do this because it was easy. And then I saw her at the past CSM and told her what I was doing now, which is pretty much fruition out of that project. And she just nodded her head. It didn't surprise her at all. She always said, you will never, you have no idea what you're going to be doing down the road, and your perceptions will change. So keep preaching that to your students. That's valuable advice. Out of all the continuing education courses that you've gone to, what has been the most helpful in working with older adults?
My vestibular competency. Yeah. So I highly recommend that anybody who has any kind of interest in geriatrics, you need to understand the vestibular system. So that is the best thing that I think I ever did.
Who did you take that through?
Susan Herdman's group, the APTA.
Oh, okay.
Yeah. Right. So that's I think it's done, well, at least when I did it, it was a 6-day really focused course. And then you had your lab competencies and your written exam all within that time frame. And you can do intro courses before that. I did a couple small little intro courses. There's a lot of opportunity for vestibular coursework now. I would say that Susan Herdman's, at least my experience was, it was very valuable to me. It was well done at the time that I took it. So
okay. So in your days in the clinic as a clinician, what were some of the most helpful apps or pieces of technology that helped you throughout your day?
Well, there's a new app that I really use that I've just started using now called Dementia Assist. And it's a free app. And I would recommend that anybody, this is the other thing. So like I try to tell other therapists that I'm in an outpatient orthopedic center. Okay. And yes, the therapists there know that I will help them with the geriatric clientele. I have seen more dementia in Texas than I saw in Florida.
Interesting.
So, yes, I find it very interesting. So, I have this app, and I, recommend it to everyone that unless you're like a specialist in dementia, which I'm trying to improve my understanding of the many facets of dementia and the many types, this is very helpful because it gives you ideas about what kind of behavior thing is happening or maybe a sensory loss that is occurring. And you can work through that app. It's awesome. And this app was created by Teepa Snow, and her work is excellent. And she's an OT in dementia.
All right. And for all the listeners, I'll have links to, the app and then the vestibular course in the show notes. So you can reference that there. Okay, so last question. You have every geriatric rehab clinician in the room. You got 30 seconds to a minute. What would you tell them?
So these are geriatric clinicians who have made the choice to be geriatric clinicians. And I want them to stand tall and make sure they tell everybody else why they love this population and how important it is to treat them and the skill that is required to treat them.
Preach. Preach it. All right. Thank you, Kathy Shirley. I appreciate your time and just sharing, your career and what you're doing now. And this is exciting to hear your passion and your excitement that you're taking that into the academic setting. I know, a lot of people are very passionate in the academic setting already. I've talked to lots of them, and it's very exciting to see people like you and many others that are interacting on a day-to-day basis with students to help change perception. So we'll do our part. We'll stand tall. We'll be a little prouder and keep doing what you're doing. Thank you.
Okay, great. Thanks a lot, Dustin.
Yeah. Also, sorry, if anyone has questions or wants to pick your brain a little bit, is there a way to reach you?
Yeah,
whether it's social media or whatnot?
Easiest way is email.
Okay.
Yeah. So, and you can put that link on your website, but it's kshirley983@gmail.com.
Okay. Got it. All right. Thanks again for your time. I appreciate it.
Okay. Thanks, Dustin. Bye.
Hit me. Thank you for listening to the Senior Rehab Podcast. The show notes for this episode and much, much more can be found at seniorrehabproject.com. If you found value in this conversation, please share this with one other person that could benefit. And until next time, do not forget to stay funky.